Thank you for having me here. It's my pleasure. Thank you.
All right, so I think we can get started, and our advanced endoscopy fellow, Abdullah Al-Shahrani, is going to present some of these ESD devices. Go ahead, Abdullah.
Thank you very much. I'd like to thank everyone for being with us virtually for the APIE 2021. As we have seen earlier, excellent demonstrations of ESD and poems being done by world-class experts. We have the chance to pick their brain and see their thoughts, opinions, and experiences with some of the ESD devices that we have. I'll be talking more specifically or demonstrating more of the ESD knives, and we'll have the experts talk about what they think about them. This is the hybrid knife, which comes in 3 types, the T-type, the I-type, and the O-type. And I leave the discussion for you.
Right, so Mohammed, you and I, we're supposed to guide this discussion, but I think all of the panelists are going to join us and help us guide it. So we can get started. So the hybrid knife, as all of us know, allows us to dissect and inject through the same device. So let's just go around the table and see what procedures are our panelists using this for. Poem, ESD, both, only one of them?
Yeah, let's start with Stavros first. For the hybrid knife, I want to hear his opinion.
Yeah, I use the I-type for every poem and G poem, and probably Z poem if it's not too delicate. And that's and any tunneling in the esophagus, like a stir for a leiomyoma, I think it's invaluable. And I don't use it for ESD, it's thick and causes coagulation, and I don't use it in the colon. I know some people use it in the colon. I think that's it's too stiff and thick for the colon.
Yeah, it's so interesting that a lot of people will use the hybrid eye knife for colonic ESD, and I had the same experience. I worry about it in the colon. So, Michelle, do you also use the I or T type?
I really like the T. I think the I is just too long. Whenever I want a needle type instrument, I use the Dua or the new knife from Boston, which I actually like. The beauty about the T is not only the pressure injection, but also the ability to lift more easily the muscle. So I use it for literally every single one of my poem.
Yeah, actually, it's my preferred one for poem is the hybrid T type. But I also see that some people like I. Anyone using O type at all?
I hate the O type because it doesn't have any. It's not insulated. The tip is not insulated. This is why the IT2 is still probably a better instrument than the O type.
Hero, what do you think?
I have very limited experience on the hybrid knife, but I think the advantage would be we can adjust the length of the knife depending on the appearance. So whenever if you want to see the tip of the knife when you're cutting the muscle layer or something or making a thumbnail, I think if we can extend the knife, that would be helpful. I think the dual knife is a little shorter, or like Ori's knife is too short to see the tip during myotomy or something.
So is I was just saying, is anyone using the hybrid knife for ESD?
I am using the T knife for ESD in the esophagus. I use actually the tunneling technique for that. So I start like a poem and I tunnel it, pocket technique, and then I slice it. I also use it in the stomach, but I agree with Stavros, in the colon, it's not a good knife. The pressure injection actually is very good. You can't beat that pressure injection. But the cut itself, you can do it with the I or T. It's just too big.
All right.
I think the knife is got incredible injection ability. And I think in areas where they're wide open and you're tunneling, I find it's very good to use. For ESD, I think the knife is quite thick and there's a lot of cautery effect. I think the electrical density of the knife isn't very optimal for it. And sometimes when the knife goes, you're moving positions, the knife can actually go in and out during the procedure. So I like it for tunneling.
When you use it, do you adjust the length, or do you guys get all the way out and leave it out all the procedure, or you adjust the length when you're working with this knife?
I mean, we adjust the length at the beginning. You have to start with a minimum length, and then once you're in the tunnel, you can use the full length. You need to demarcate your different plane, and typically for the myotomy part of it, I use the full length, but I make sure that the black marker and the white marker, both of them are exposed outside of the field of cutting. You can. I always teach my fellow the white marker has to be literally above the muscle when you're doing the myotomy.
All right, let's move on to the next slide. So since we're talking about POEM and tunneling, I guess we can talk about the triangle tip knife. How many use the TT knife routinely for their POEMs versus hybrid versus anything else? And what do you like about this knife?
I mean, the triangle tip knife is the classical instrument of Inoue. This is how I learned to do POEM. It's a great instrument. The problem is the original knife didn't inject, and that probably is the thing that make you lose time, as you guys know. The J is nice. I always feel that the J has a smaller surface, which during the myotomy can be a little bit frustrating because you have to go twice during the myotomy. So, but it's great during ESD. So the triangular tip J knife, I use it mainly for ESD, not so much for the POEM.
Do you notice more bleeding with a triangular tip knife, the smaller one? The triangular J, because it's smaller sometimes and the muscle is not able to get it all entirely. So sometimes it causes bleeding compared to the wide T disc from the hybrid one. You feel like
that's probably related to the decreased coagulation because the surface of coagulation is smaller. So that's probably an indirect consequence. The biggest problem is you have to go twice in the area of myotomy, and that is very time consuming.
Ken, do you have any comments about hybrid knife and TT knife?
Yeah, my go-to knife for all POEMs, Z-POEM, G-POEM, E-POEM is the hybrid eye knife. That's been my go-to. And most of my ESD, esophageal and gastric, I tend to use it because it's because of the injection water jet. The only exception is for G-POEM, I finished the myotomy with a hook knife because you just really need to have a lot of precision and control when you're doing the pyloromyotomy. I don't have as much experience with the TT knife.
So coming back to Mohammed's point, I did use the TTJ knife to do POEMs, and I found in the few cases that I did, there was more bleeding, especially during the myotomy. And I think because the knife is smaller and maybe a little more focused in doing the incision rather than the broader tip that you have, and maybe less coagulation that was just mentioned. So I think sounds like we can move on to our next one. I know we have a bunch of devices to go through, including closure devices. And I know a lot of people in the audience are interested in how we close defects, whether the people in the audience are doing POEM or ESD, they still have approached about how we close things. So let's keep moving.
Okay. This is a dual knife, which comes in two sizes, 1.5 millimeters and 2.0 millimeters. And it has a dome-shaped cutting section.
So I think I can pick on Hiro. Hiro, you want to comment on the dual knife, and is that your go-to knife, or what? How are you doing your ESDs?
Yeah, thank you. So so the dual knife is one of my go-to knife. I'm currently choosing between the Ori's knife versus dual knife. The biggest difference is the injection coming through the catheter or needle itself. The Ori's knife allows the injection to go through the needle, which allows more focused lifting. But I still like the dual knife because the body of the catheter is very slim. So even if I'm using the 2.8 millimeter channel, I still have the suction capability compared to the ORISE knife. So whenever I'm using the upper scope with the 2.8 millimeter channel, I still prefer using the dual knife. Other than that, I use the ORISE Pro knife.
Amit, any thoughts?
I love the dual knife. It's probably my preferred knife for ESD. I think the curved dome at the end of the tip allows for a very smooth dissection. And for most ESDs, the length is adequate and you have good visualization of the knife during dissection.
I think it's a Mercedes of ESD devices. Depending on what type of car you like.
I would agree with that statement.
Okay, any other comments about this, or can we move on to our next one? Abdullah, go ahead.
Okay, next is the insulated tip knife, and it comes in 3 forms: the IT knife, IT2 knife, and the IT nano knife.
Mohammed, you want to get the
Yeah.
discussion going on this?
Yeah, so we have 3 iterations of this knife: IT, IT2, and IT Nano, and their location is different. So maybe Stavros can teach us about the difference between the 3 knives.
That's unlikely. I keep buying them and they keep expiring. I have them mainly for my live course. Yeah, I keep thinking I'll use them at some point, but it just never comes up. I tried them. I think they have their own learning curve. I mean, I used to think you have to hook the tissue to cut it. Obviously, that's not how you should use it. You need to really push on the tissue and the spark cuts. You can't just grab a big chunk of tissue. The other thing is beginners like them when they cannot get under the flap. They can sort of sneak them under the flap and start cutting like a scythe. But the problem with that is you hit the vessel under the flap, you'll never see it, it'll start bleeding. That means you have to use them with high spray or coagulation currents, which then tends to cook the specimen. So I don't know, I never really got warmed up to them. I tried them, I mean, I definitely tried them. I just, I percolated to basically dual with hook for the difficult parts for the colon. No IT nano or other IT, and for the upper, as I said, hybrid and then dual. But then the last 3 years, as the other speaker said, the last 2 years, the Pro knife killed my dual usage. I mean, completely. Like colon ESDs went from 100 to 120 dual plus minus hook to Pro knife completely. So it's my Olympus rep is a little distraught over the past year. But as Hiro said, the injection through the Pro knife, which is very similar in morphology as the dual, is amazing, amazingly useful compared to, say, the dual J. So again, unfortunately for the insulated tip, I don't have any particular comment or use.
I think we started to develop culture, and a culture now for United States that all of us use something like dual or Pro knife, and you complete all the procedure with it. And I think this is how we train people. When I went to Korea, I found that the IT knife or IT2 exactly is the main knife they use, and they would use the regular needle knife to make circumference and incision, but all the procedure all the time done by IT knife. Hiro, what do you think about ITUs in your practice? Because I think in Japan they use it a lot too.
Let me say a comment. I mean, I've seen Japanese like Uedo use it amazingly in the stomach in a proximal lesion with traction. It works fantastically. It wants me to go back to my place and start doing it. And then I try and it just doesn't work so fantastically. I think it's good for gastric lesions that you don't have much of. And that's why we never get used to good at it.
Yeah, it's mainly gastric knife, and I think so. And the nano, they made it for the colon, but let's see what Hero think.
Yeah, sure. So I still have the IT2 and IT now in my toolbox, because sometimes in gastric ESD, whenever you have some difficulty in approaching to the target area, especially in the gastric fundus or the posterior side of the gastric cardia, sometimes it's hard for the needle type ESD knife to keep like a contact with the area because of the respiration or heartbeat. In that case, I usually hook the incision line and then just drag the knife to finish the incision. And that's the only situation I use the IT knife.
So anyone else use it? Amit?
I'll actually give a counter argument. I actually use it quite a lot. And maybe because the people who I learned from, IT is part of their practice. I think the difficulty is dissecting with an IT knife is very different than dissecting with a needle knife. So you cannot use the same technique. It is almost that you have to hook, torque, and put enough tension on that submucosa to dissect. And you have to change your electrocautery settings. Because the knife is longer, you actually need a higher setting to be able to cut. But once you get the technique down, I find it's actually much quicker to dissect with the IT knives than it is with the dual. Or if you have to make large mucosal incisions, this can be done much faster with an IT knife than a dual knife. The differences between the two knives, or the IT2 knife, if you see the back blade, it goes all the way to the end of the insulated tip. So that was safe for gastric ESD, but when they started using it for colonic or esophageal, it can result in perforations from those short blades. So the IT Nano, the disc on the back of the insulated tip, doesn't go all the way to the end of the insulation, protecting the muscle layer and allowing for safer dissection. And also we actually use the IT Nano for esophageal ESD. The submucosa in the esophagus is so loose, you can actually put the entire insulated tip into the submucosa and use the back blade to dissect through the submucosa, allowing for very fast and safe dissection.
I think I agree with Amit in the situation of the esophagus, in that if you really get to this situation that there's loose fiber, that you don't know where is the specimen is hanging on, you can just use a knife and go down, up all the way, cutting all the fiber and release your specimen. But I would say it is a just different style of work. And if you start working with the dual or brew knife style and get closer to specimen, you use IT2 less. So I also agree with Stavros. I know exactly what he's talking about, but I also know exactly what Amit is talking about. But also that's the beauty of ESD, that there's many devices, many ways of thinking about it. Any other comment?
Yeah, I really like the IT2 when I have a tortuous esophagus and I'm doing a palm. Those are the one when you really are concerned when you do the myotomy that you're gonna have a mucosal injury. And the insulated tip is very protective in those cases. And sometimes when it's very tortuous, you actually need to do what I call a reverse myotomy, where you actually grab the muscle and you bring it towards you when you're doing the myotomy. And that there's no better instrument than the IT2 for that. I also like it when I do the pyloromyotomy. When my tunnel is done, I like to grab the pylorus and do my myotomy. Actually, when I travel and I do third space in a foreign country, there's always one knife in my luggages. It's the IT2.
So what about using it for doing septotomy instead of Z-palm?
Well, as you know, I'm not a big fan of septotomy, but if I have to do a septotomy, it will be also with an IT2, simply because the insulated tip is really a very attractive option of the knife. Another very good indication, I believe, is when you're doing a stir. There's a moment in the stir when you've done your tunnel and you're about to deliver the gist or the leiomyoma from the muscular layer, where you put the knife literally in the mediastinum and you deliver the gist into the tunnel. That moment, you really want something insulated to go on the other side of the muscularis. And there's nothing like the IT2 for that.
I agree. And I think, we're hearing all these different opinions. So there was a question that just popped up, as in, what is the best knife for colon and rectum ESD for beginners? And I think there is no best knife, and maybe for beginners, the colon may not be the best place to get started. But in the interest of time, I think we're going to keep moving. I know that this discussion is getting livelier with all these different opinions, but Abdullah, let's keep going. And we briefly heard about the hook knife. So where are folks using the hook knife, and what should we be careful about when using the hook knife?
I mean, the beauty about the hook knife, it can really cut in any angle. You can change the angle, and you can really use it in literally any position, in any angulation. It's a great knife when you have scarring. I've noticed I like to use it when there's scarring, and it allows you to pretty much dissect whatever you want. But the problem is you can perforate very easily. So this is not a knife that I recommend using if you're just starting to use ESD.
Yeah, I would second that, Michelle. For incisional therapy of strictures, for beginners, I would maybe start with an IT2 because it has a hook knife kind of built inside the installation. So you can start with that, but then the hook knife really helps with the strictures.
Right. I've moved to the Z-Poem technique, but if I were to do a traditional septotomy, the two knives that I would use would be a hook knife, and the other one would be a scissor type knife to do a traditional septotomy for Zenkers. But otherwise, I would agree with all of you that it's quite a scary knife if you don't use it appropriately, and can cause serious issues. All right, can we look at our next device, the flush knife?
Who's using flush knife?
That's what we'd like to know.
It's a very, very popular knife in Latin America for some reason. Like every single one of my trip, there's some guy who's like popping out with a flush knife in his hand to make you use it. I think it's a decent knife. I still prefer the dual knife compared to the flush knife. But if you want to do an ESD and you have this, it's a decent knife. It's not my favorite knife, but it's definitely a decent knife.
All right. So in the interest of time, if most of us are not using this knife, let's move on. We heard a lot about this knife. Anyone has any additional comments about the Orize Pro knife?
Yes, I don't like the 1.5 at all. I feel sometimes even it is dangerous because it's superficial. The 2 is perfect. I agree with the staffers that I start to use it more and more. Initially, I was so skeptical about it. I was feeling it's not going to work. And then with time, I start to like the injection and cutting, and I feel the injection is better. But there's something else I noticed about it. There's this flat disc. It's provided maybe wider coagulation, so you don't have as much bleeding, especially if you move slower. And I start to feel that my cuts are cleaner. So I'm using it more and more. Same like my other colleagues here. The 3mm, I have used it for palm too, and it worked very well. I'm not sure if it will be better than the T knife, but I would like to hear from the others. What do you guys do with the Pro knife?
I've started using it recently, and I agree with Mohammed about the 2mm. I think the 2mm is right about perfect. The 3 is too long. The 1.5 is too superficial. So the 2mm is exactly where it is. I actually have done an ESD with this in the recto sigmoid, and I think it's a pretty good knife. One thing that I've noticed, though, and I don't know if Mohammed is going to second this, the pressure of the water comes out very nicely. So sometimes I have issue with the Dua J, and I feel frustrated about my ability to lift. I don't know exactly what they did, but the lifting ability of the 2mm Orize is actually pretty interesting. I don't know if Mohammed or Kenneth have felt that way too.
Yeah, I've tried it on a couple of cases, and through the needle injection is a definite plus. When they hook it to the pedal, there's a delay, so the response rate to the pedal and the water coming out wasn't acceptable to me. So, but using just the syringe and pushing with our tech seemed to work really well.
Yeah, I noticed the same, and also there's something also about the dual knife J that every time you inject, you have to put the needle back and push so much again as
Yes.
the tissue to inject.
That is so annoying. That's
Yes.
so annoying.
But this one you just inject when you are cutting even, and then my technicians, they love it because they use a syringe. We don't use a pedal, it didn't work. But with a syringe, you cut, inject, and you find you're going very quickly doing it. And so I start to like it, although I was not believing that it would work at the beginning, and now I'm slowly using it more and more, and I have to admit that.
Yeah.
Actually, the Orize knife is my go-to knife for my colon ESD because my nurses and techs really like it because they can fix it open and then the length is fixed. So it's they can do like other things too. So
do you use 1.5 Hero or 2?
I started to use like a 2. I used to use the 1.5. This is from my dual knife experience, but I started to use 2 for colon ESD and it works very well.
All right, and I'm seeing Dr. Pokola on our panel now. She's getting ready to do her part of the presentation on the closure devices. So I think, Abdullah, we need to move on. I think this is our last device in the knives. So this is the scissor type knife, the clutch cutter or the SB knife. So Michelle, I saw you unmuted yourself, so maybe you want to start.
Yeah, I think if you have a very nice tunnel and a non-tortuous esophagus, it's a nice instrument to use. I've used 2 or 3 of those in Latin America. I'm not a big fan. I think you need to find a good case for this. Not every myotomy is good. I know that a lot of people use it for septotomy. As you know, I'm not a fan of septotomy, but that's also probably a good scenario.
This is my go-to for every poem when I get to, so I'll use the eye knife for the submucosal tunneling and the circular myotomy, but when I get to full thickness, I switch to SB knife. It works so well because it's compressing the vessels that you don't see in between the muscle layers or outside the muscle layers. It's capturing and you coagulate them confidently and cut. So I feel it's fast, efficient, and the number of spontaneous bleeds is almost 0 with this.
All right. If we don't have any other comments, I think we'll move on to Dr. Pokola. She's one of our GI fellows, very interested in interventional endoscopy, and she's going to demonstrate and show us some of these closure devices that are out there. We have quite a few new devices there now, so we'll get a quick overview from our panel, and we are running late, so we'll try to stay on time. So go ahead, Kusuma.
Great, thanks for that introduction. So we'll go ahead and jump right in. The first device that we have to discuss are the over-the-scope clips. And the first one up is from Ovesco. There's 4 sizes with 3 different types of teeth. So and there's also a new stent fix clip as well. So excited to hear what you guys have to think about these.
Are you still using Ovesco? Let me ask this way.
Stavros, you've been quiet for a while, and
not much, or hardly ever. So I'm not a fan. So I'll yield the balance of my time.
Okay. So I have been using it for fistula closures, using APC to ablate the fistula, sometimes even ESD if it's a chronic fistula to get more preparation of the tissue. And then if it's a small enough fistula, put an Ovesco or suture it. Otherwise not. I'd be actually curious to know, are people using the stent fix version of this clip to fix, or are people still suturing stents? What's everyone doing?
We did a few stent fix with the Ovesco version of the fix. We've had decent results. I think we need more data. It's just too early. I don't know how many people are actually, using it. I know most people are suturing stents. So obviously we're gonna need more data on this before really have a clear understanding if it works or not.
And can I say a word of caution about Ovesco quickly? And I know we're running out of time. Is that initially, when I was less experienced, I was using it more after ESD if I have a birth or something. And I noticed later on that first, they don't come out. And second, two of my patients had persistent pain. And you could see that the Ovesco clip growing in the muscle. So I had to do almost ESD to remove them before they had this opening device. And even if you have it and it's just so deep on the muscle, it's almost going outside of the lumen, it can rub again in the serosa and cause pain. And I had to remove them. And once you remove them, the pain is gone. So I stopped using them post ESD maybe a few years ago, around 2016. I stopped using them, or 17, because of pain post procedure.
Yeah, let's move to the next one.
So
Anyone using the padlock? Sorry, I didn't mean to interrupt.
Nope, that's okay.
I mean, if removing the Ovesco is difficult, this thing is like, this will tear apart everything that it has grabbed. So I personally don't like it at all.
Okay, so I think Kusuma, you can go to the next closure device. Go ahead.
Oh, so the next device is the X-Tac. It can be used with gastroscopes or colonoscopes for defect closure. Is anyone using this?
Yeah, we recently started using it. We really like it, actually. And I believe it's going to have a major role in closure of fistulas, leaks. I actually started closing my GPOM with it. And I've been having some decent results so far. They all sealed perfectly. So
yeah, I'm presenting a video case at the end of the in the video session today on closing GPOM with X-Tac. We've had some good success with that as well. So others using this for EMR or ESD defect closures?
I think it has a learning curve. And the more you use it, the more you discover. I will tell you that, yes, I'm excited about it, but after I use it for a lot of post-ESD, colonic ESD, sometimes it can open up if you have a large defect. I wish they had more than 4. I wish it was 5. But I learned something now with time, is that you can close it and quickly put 1 or 2 clips, especially for large defect like 6-7 centimeter defect. You can get it all closer, and then 1 or 2 clips, and then you are done. And you don't have to struggle putting 1 clip here and there and go through this like 8-9 clips. So I start to like it, but I just feel that we shouldn't think about it as a complete closure by itself, but we should think about it as something will help us to get all edges together, and then you add another clip or 2. So I feel combination of X-Tac plus 1 or 2 clips. But I would like to hear the panel's opinion about that.
Yeah, we've done a lot of this from the beginning, but I wouldn't use it for any full thickness holes, even small ones, or EFTR, or things like that. It's not secure because it's metal to metal. It doesn't really oppose the tissue the way overstitch would. So I wouldn't use it. I was excited when it came out for using it for EFTR in difficult areas like the duodenum and whatnot. It's not secure for preventing leakage from full thickness defect. So covering an ESD defect, we do that. But if there's a perforation in the ESD, you should really try to suture it over.
Yeah, so it has its limitation. I feel like it is good, but it has limitation. But I feel you can use it still for closing leaks or something if you put clips above it. I mean, like, it can get things closer, maybe like strengthen it with clips, or you just go. I feel perforation suturing would be better just right away, and maybe we'll see that later.
Right.
And or maybe somebody has to study that suturing versus X-Tack for perforation
Well,
closure.
I spoke to Chris Gostad, the medical officer for Apollo, about what's their data on full thickness closures, because I was sure they did some animal. He told me, like, 1/4 of the pigs they did full thickness on got peritonitis and died. 25% leakage, that doesn't sound good, even in animals. So I don't think that he doesn't. It's not one of the indications for full thickness closure because of this. I mean, they clearly did not seal the defect in 1/4 of the animal. So I'd be careful about anything that has a perforation.
I agree.
Yeah. I think sticking with the principles of physiology, this is a great addition to our toolbox because it's a great way to approximate tissue, but it's not going to close or seal, right? Whereas clips approximate, close, and seal if it's small. Large defects, sometimes we have trouble just approximating. This is the solution to approximate, and then you close and seal.
I agree. And I think this leads into our next few slides. And I know, Kusuma, you can advance to the next one, to large diameter clips, which are now available. And I know we are running short on time, so I'm just going to make a point that I agree with both Ken and Mohammed. The goal here is to bring the tissue together with these newer devices, whether it's the larger clips or X-Stack, and then you can reinforce it with other clips that you think are stronger and can hold tissue. I don't think X-Stack is designed for full thickness closure. Actually, their animal studies, the paper they've published shows that it does not go into the muscle, but is superficial to that. So I think let's get an opinion or thoughts from our group about these different clips, which are larger than the standard clips that we are used to.
Yeah. Let's ask each one of the panelists to choose one of the four. If you choose one, what would you choose? Michelle?
Yeah, the Dura clip. I'm really comfortable. I've been using it for quite some time. It rotates pretty nicely. I've had some decent result with it.
Dura. Stavros?
I don't use large caliber clips, but I use resolution for most of the regular ones.
All right.
But I like the precise rotation better. I mean, the rotation is more precise than other clips.
Ken?
Yeah, a Dura clip, especially for poem, it has the shortest stump.
All right, Hiro. I like the resolution clip, physician control portion. And then for the traction during ESD, I like the dual clip because of the shorter tail. So.
I like the resolution clip as well. I think the precise control over rotation, being able to rotate it yourself is very nice.
Yeah, that's amazing. What about, is everyone, did we get everyone here?
I'll make a quick comment. So I use the Dura clip. We've been using the 16 Dura clip for a while now, but we've tried all the others. I haven't tried the Eco clip. The Instinct Plus is a good clip as well. I think there were some initial issues about deploying the handle to deploy the clip, and I think they've worked through some of those issues. The Resolution 360 Ultra, we have some that we are trialing, but I think we've been using the Dura Clip 16 for a while, and that's our clip for bringing tissue together, and then adding some other clips if we need to kind of reinforce that site.
That's good. I actually, for my poem, I use Dura clip, but if I have to choose one of the four, I will choose an Instinct Plus. That's my go-to clip for any closure. It's very strong, and because it has a second, it has reinforcement, so it can really bring all tissues together. But this is amazing. See how everyone has different opinion about things. That's cool to see that. Can we go to the next device?
Yep. So the last one is just the Locato clip that comes in 16 or 22 millimeters. The only one to come in that larger 22 millimeter size.
Yeah. So this by far is the largest device we have now, 22 millimeter Locato. One of my partners loves it. But I feel like if you bring tissues that far away together, you really have to have more strength. Anybody tried that for large closures or post ESD?
It's a pretty nice clip, but a little bit to the same concept that Ken was saying. It's very nice to use it to approximate. Like if you have a pretty large defect, this is the first one you will place, and you can finish it with more clips. So this is actually a great approximator.
I like that, Michelle. You call it the great approximator. That's the best way to put it, because we've used this clip and I have the same issue. It brings tissue together, but as soon as I've placed it, I've said, give me something else quickly, because this is going to open up right there in front of me. And then we've secured it with some other additional clip. So I like that, the great approximator. So any other comments about this large clip? If not, we have a question from the audience, and that's probably the only time we have. The question is the cost of different types of ESD knives similar, and how does that factor in when you're choosing the knife when doing ESD?
I feel like in your unit, you have to make sure they are similar, because if we'll have a problem with that, you'll have a certain price. And when the next vendor comes to you, tell him, I cannot get your knife, is more expensive. So you should strive to that, but you should know that the price of these knives will be varied from how many procedures you're using and your healthcare system, and whether you are under, certain agreement or not. And so for cost is different. You'll be surprised to know that each one of us will have a different cost based on the agreement of the hospital, and also based on the special discount they'll do based on your volume. What do you guys think?
I mean, there is no universal knife, okay? Each knife has advantages and disadvantages, can be used in different technique. It's very important to make it clear to administration that you're not going to be working with one single knife. That's an illusion. So it's like starting an ESD and you have only one knife. It's just not an option. So it's very important that you have to incorporate this into a program, and your administration need to support you. They can't say, oh, no, I'm sorry, we're not going to get you this knife because we don't have a secure contract with them. That's just simply unacceptable. And I think the problem we've been seeing, I'm sure many of the people on that call are going to recognize, it has become more and more fastidious to deal with administration. But I want to give you all a message. It's everywhere. And it's very important that we stick together and make it clear to the administration that they don't dictate, what other device we buy, because we don't want to ultimately treating the patient.
I like that. So there's one comment from Andy Tao. I'm very proud of him, was one of our fellows a few years ago. X-Tack can be removed when using a resolution 360, which has a strong enough torque to unscrew it. I never tried to remove the X-Tag before. I don't know if anybody thought about removing it.
I have not, but I'll be showing in the video case what we learned from our first few cases is that you really need to get that X-tack, the helical tack really into the tissue. Otherwise, when you go to place the next one, the first one can get dislodged. So I think I've never tried removing it, but I try my level best to push it in as much as I can and really screw it in before I go to the next site.
You can remove the last one you placed by sticking the deployment catheter back in, by holding counter tension on the suture, and then you can unscrew it. Mm-hmm. But the last one, the ones you have already placed, it's going to be more difficult to freehand jam the catheter back in until it clicks and then unscrew them. But the last one is easier because you have the tension of the suture as a counter tension. So you can use the same catheter to unscrew.
It's a good tip. I like it.
All right. Well, Kusuma, thank you for putting this together and leading us onto our various opinions. And as you can see, there's no one right way of doing any of this. All of us have our, quirks and preferences. But thanks to everyone for being on this discussion. This was just a trial. We said, let's just open it up and have a discussion. I'm glad that we could all share our thoughts. So thank you so much. We're running late, so let's move on to our next lecture.